So, hi guys, how are you all? So let's check the quality, audio and visual before we start. Okay, so I think everything is fine. So let's quickly start. So these are 10 important IBQs for INICT. Basically, just a quick recap of how what all questions can be coming. So we'll just have a quite quick recap of it. So today we are going to just discuss the 10 IBQs, and then on 5th, before your INICT, we'll discuss some tentative exam questions also. So let's quickly come to the quiz. So it will be a quiz. So let us let's see how many of you can answer this question. Okay. So question number 1 on the screen is, let's see. Just a second, guys. Okay. Just one sec. Right. Now we can start. So first question on the scene is neurosecretory bodies are seen in all except. So guys, neurosecretory bodies are nothing but they are seen in neuroendocrine tumor. So whenever we have a neuroendocrine tumor, we see neurosecretory granules. Okay. So whenever we're talking about these, so out of these, which are the neuroendocrine tumors that you should know? So remember, the first and foremost is paraganglioma. Yes, it's a neuroendocrine tumor, right? Pituitary neuroendocrine tumor, तो neuroendocrine ही लिखा है, तो it's neuroendocrine. Medullary carcinoma of thyroid is also a neuroendocrine tumor. So all the three are neuroendocrine tumors. So definitely they will have dense core granules. So these are also called as dense core granules. So they will have them. And of course, you should remember that adrenal cortical tumor is not a neuroendocrine tumor, so it will not have dense core granules, right? So the answer to this question was clear, and it was also a PYQ which came in your exam in your INICT last year, right? So very important question again, which everybody should be knowing, okay? So if we go to this image that can be asked to this, so they can change the image anyhow. You should be able to interpret this image. So these are just ball-like inclusions that you're seeing here. So these ball-like inclusions here are nothing but dense core granules, which you should all remember. Okay. So these are your dense core granules. Now, coming to the paragangliomas, how do we classify them? Remember always, whenever it is an intra-adrenal, it is also called as pheochromocytoma. And whenever it is extra-adrenal, it is a paraganglioma. So it can be, depending upon the location, it can be a carotid body tumor, it can be glomus tymphanicus, glomus vagale, it can be aortopulmonary or laryngeal. Okay, but whatever is it, the characteristic microscopic feature of all the paragangliomas is Zell-Balin pattern, which all of you know, that is it is like a coating by the sustentacular cells. So there are special cells which coat the cells outside like a island, and these cells on the outside are called sustentacular cells, and they are always positive for S100. So you will see these nests of tumor cells outside, they're surrounded by sustentacular cells. Always remember that this pattern is called as Zell-Balin, and that can be asked you as a question again. Right. Let's come to the next image based question, which is again a very, very famous question that can come in your exam. So what are these? So these tennis racket shaped structures, and if they give you with the skin rash, you should always remember that this is an electron microscopy of Burbeck granule, and it is typically seen in Langerhans cell histiocytosis. They can ask you the markers for this. Always remember they will be positive for S100, they will be positive for CD1A, and they will be positive for CD207, which is nothing but Langerhans. So these are the markers that you should always remember in these cases. And this is your LCH, which you all remember. Now coming to the next one. Okay, so this is another electron microscopy that they can give you. Here you can see these here, like these. So when they give you this kind of an image in the electron microscopy and they give you an history, let us say 4-year-old child presenting with difficulty in standing up or myopathies, you should always remember, always remember that this can be a mitochondrial myopathy, and this is what is called as a phonograph record. Okay, so this is what is called as a phonograph record. So this kind of electron microscopy is very typical for mitochondrial myopathies. Apart from that, they can also stand it like this. This is actually standing like a parking lot. Okay. So these are basically rhomboidal crystals which are standing like this. So these are called as parking lot inclusions. Okay. So these are also called as parking lot inclusions. So both of them are very characteristic for mitochondrial myopathy. So whenever we have a mitochondrial myopathy, we can have phonographic records or we can have parking lot inclusions, which you all should remember. Apart from that, you have to remember a pedigree of mitochondrial myopathy should always be known. So whenever a mother is affected, all the children are affected. Okay, whenever the father is affected, none of the child is affected. That's very characteristic of mitochondrial myopathy. And they can give you an image based question also on this. This is a very typical stain. This is called Gomori trichrome stain, and on this you can see that there are red fibers on the periphery. So this is called ragged red fibers. What are they called as? Ragged red fibers. Okay, so this patient usually present with myoclonic epilepsy. So that is why this disease is also called as MRF. Okay, that is myoclonic epilepsy with ragged red fibers. And whenever you look at this condition, always remember that the electron microscopy will show you phonographic record or will show you a parking lot inclusions. Okay. Right, coming to the next question here. So this is a 12-year-old male presenting in the emergency with fever, and this is what is seen in the peripheral smear. So this peripheral smear is typical, very typical, because these are like blisters. Okay, so half of the cell is vacant. Okay, so the hemoglobin has moved to the other end, so one half of the hemoglobin remains vacant. So such cells are called as either a hemighost cells or blister cells or bite cells. Okay, so all these cells are very typical of G6PD deficiency. Okay, so these cells are very typical of G6PD deficiency. So the question can be, what is the next test that you will do? So whenever you look at this, you will always go ahead with a supravital stain, because in this patient you will have to document Heinz bodies. Okay, so Heinz bodies you will usually be attached to the membrane, and so you have to do a supravital stain to document the Heinz bodies. And after that, what is the test that you can do here? So screening test is methemoglobin reduction test, which you have to remember. Okay. So if somebody asks you what is the most common type of G6PD deficiency in our country, in India, the most common type of G6PD deficiency is G6PD Mediterranean, which is very common, followed by G6PD Odisha, which is very common in Odisha. And the third most common is G6PD Kerala Kalyan. So majority of these are point mutations, and you all have to remember that whenever a patient has a G6PD deficiency, usually the older RBCs are affected. So the patient usually has a history of intravascular hemolysis. Okay, and the older cells, because this, free radicals start accumulating in the red cells. So I'll not go into the pathogenesis here. I hope all of you will be knowing that. So that is why older RBCs are more affected. Okay, so that is why testing should never be done immediately after a period of hemolysis. Okay, so you should not do testing immediately after the period of hemolysis, because immediately after hemolysis, reticulocytes will be there, which are younger RBCs, and they will have adequate amount of G6PD deficiency. So milder G6PD variants will be missed out. Okay, right. Coming to the next case here. So this is a 7-year-old female who presented with anemia and mild jaundice. She had required transfusions 1 year back, and she was found to have a significant anemia, and the RBC count is very high and the MCV is very low. Everybody should remember. So whenever you get this kind of picture, when the RBC count is high and the MCV is very low, you should always go and do a test called as Menzer testing. Okay, so Menza testing is nothing but MCV by RBC. So if you do this, it will come around approximately 10.9. So whenever your Menza index is less than 13, it is very, very suggestive of thalassemia traits. Okay, it's suggestive of heterozygous thalassemias. Okay, so obviously, what is the next test that you should do once you are suspecting that this is a thalassemia trait? Okay, you should immediately go and do hemoglobin HPLC. So whenever you do hemoglobin HPLC, so this question I had posted on my Instagram also. I had posted electrophoresis there on the Instagram, and many students asked there that, ma'am, how does an HPLC looks? So this is how an HPLC looks like. So on HPLC, you have to see all the hemoglobins you can see. So you have to look at how much is the hemoglobin A. So here the predominant hemoglobin is hemoglobin A0, but if you look at the A2, it's more than 4%. So whenever your hemoglobin A2 is more than 4, it is very, very strongly suggestive of, again, heterozygous beta thalassemia, that is beta thalassemia trait. Okay, so why this happens, again, I told you a story which you have already heard in the videos. I hope you remember that. So I'll not go into the pathogenesis in detail, but remember, whenever A2 is more than 4, you should always remember beta thalassemia trait, but you should remember it should be less than 8. Whenever it is more than 8, again, so then you should start thinking of hemoglobin E, okay, which is again a very common hemoglobinopathy in northeast part of our country. Okay, so remember, so it should be more than 4, but it should usually be less than 8. That is what you have to remember here. Now, once we are clear with this, let's go to the next. Same question again, same history again, same Menzer index. But in this patient, when you do a supravital state, you start seeing this. So there is a lot of target cells on the smear. You thought that this is a heterozygous beta thalassemia because there are a lot of target cells which are seen here. So you thought that it can be a heterozygous beta thalassemia. So remember, in every case of hemolytic anemia, we should always get a reticulocyte count done, and it is done on supravital stain. So when you do supravital stain here, what are you seeing here? You are seeing that there are a lot of inclusions on this RBC. So this is what is called as, golf ball inclusions. So these are called as golf ball inclusions, which you are seeing here, which is very, very characteristic of HBH disease. Okay, so this is very, very characteristic of HBH disease, which you can see. And of course, you can confirm it on hemoglobin HPLC, which will show you a M-shaped peak in the early part. Okay, so when you see this M-shaped peak in the early part, this is very usually characteristic of HBH inclusions, and I hope everybody know HBH is nothing but beta 4. Okay, so it is made up of beta 4 chains. Now coming to the next question. So 35-year-old male with jaundice and deranged AST ALT, what is the liver biopsy showing? So here you can see that these are very homogenized hepatocytes. They are homogenized pink color. These are called as ground glass hepatocytes. Remember, ground glass hepatocytes are always seen in chronic hepatitis B infection, and it is usually due to HBS antigen. Okay. In contrast, in the same patient, they change the image to this. That is, they show lymphoid follicles here. So whenever you see a lot of lymphoid follicles in the liver biopsy, and you see a lot of bile duct proliferation, which you're seeing here, this is usually a case of hepatitis C virus. So hepatitis C virus shows you lymphoid follicles and a lot of bile duct proliferation. Actually, initially there is bile duct damage, and after that, because bile duct usually, so there is a lot of bile duct damage, so stem cells get activated and they start causing bile duct proliferation. So lymphoid follicles here in the portal tract with a lot of bile duct proliferation should take you towards hepatitis C. Coming to the next, again, I'll change a question here. So this is a 6-week-old infant presents with conjugated hyperbilirubinemia, and the HIDA scan was not suggestive of EHBA. Liver biopsy shows you this. So guys, whenever you see in a child, you see these hyaline globules, a lot of hyaline globules on the liver biopsy. This is very, very suggestive of alpha-1 antitrypsin deficiency. So This alpha-1 antitrypsin deficiency is a misfolded disease. So what happens is there is misfolding of the alpha-1 antitrypsin, because of which this misfolded protein is not transported from the endoplasmic reticulum to Golgi apparatus, and it starts accumulating there, and it appears as hyaline globules, and it is usually past positive. So this is very, very characteristic of alpha-1 antitrypsin deficiency, because it starts accumulating in the endoplasmic reticulum. So it produces a lot of endoplasmic reticulum stress, and this causes unfolded protein response, which you have already studied in the general pathology. So please remember, it is one of the diseases of endoplasmic reticulum stress that you all have to remember. Now, once we are clear with this, let's go to the next question here. So this is a 2-year-old male presented with pallor, and you can see two types of RBCs here, microcytic hypochromic and normocytic normochromic. So whenever you are seeing two types of RBCs, microcytic hypochromic and normocytic normochromic, it is actually a dimorphic peripheral blood smear picture. So whenever you have dimorphic peripheral smear picture, your mind should always be thinking of sideroblastic anemia. Now, what do you do next? What should you do? You should, once you're suspecting sideroblastic anemia, go ahead and do a Pearl stain. Okay. So once you do Pearl stain here, what do you see here? You are seeing that these erythroblasts are covered by iron in more than 1/3 of the nucleus. So they are nothing but they are ringed sideroblasts. So here you are seeing ringed sideroblasts. So all these RBCs, all these erythroid precursors are covered by blue colored granules. So they are nothing but ringed sideroblast, which you can see here. That's seen on the Pearl stain. You should always remember. And always remember that whenever we're talking about sideroblastic anemia, there is basically defective incorporation of iron into protoporphyrin, or there is a mitochondrial defect because of which heme is not formed. So what happens is your body think that, okay, why heme is not formed? So it will start increasing absorption. So in sideroblastic anemia, your iron levels will be high, your transferrin saturation will be high, your ferritin levels will be very, very high, but your TIBC levels will usually be normal or low. Okay, so that's the profile, that's the iron profile of sideroblastic anemia, which you all should remember, and many queries has been asked to me regarding this. So remember, that's the typical iron profile of sideroblastic anemia, which you should always remember. So if you put a Pearl stain on the bone marrow, what will you see is you will see ring sideroblast. You might see ring sideroblast here. Okay, and usually the iron content will be higher. Okay, so let me show you that. So this is how, this is the particle in the bone marrow, and it is full of this blue color, that's iron. Okay, so it will have usually iron overload. Okay, so iron will be loaded, but still on the peripheral blood there will be dimorphic peripheral smear picture, because heme is not properly formed, because iron and protoporphyrin is not properly formed. Okay, so they can't combine, there's some defect there, and due to which heme is not formed. So it can be inherited or it can be acquired. So inherited is, you can be X-linked, or it can even be autosomal dominant or recessive. X-linked are more common. But remember, in acquired, you should always remember vitamin B6 deficiency. You should always remember can cause sideroblastic anemia. Apart from that, you remember antitubercular drugs like INH, zinc overload, copper deficiencies can also cause your sideroblastic anemia. So acquired alcoholism can also cause sideroblastic anemia. So these are acquired causes which you should always remember. Once you're clear with this, remember the principles of Pearl stain, guys. So what is the principle of Pearl stain? So usually your hemosiderin contains iron in the ferric form. So this ferric form, you put it in the dilute hydrochloric acid and you use ferrocyanide. So you use ferrocyanide in the dilute hydrochloric acid. So as soon as the dilute hydrochloric acid reacts with the hemosiderin, the ferric ion is released outside. This ferric combines with ferrocyanide to form ferric ferrocyanide, which gives you blue color, and this is the principle of Pearl stain. Okay, so this ferric ferrocyanide which is formed is actually your Pearl stain. It gives you the Prussian blue color. Okay, so that is what you all have to remember. Now, if sometimes, they can ask you a question. So this is an image from ASH blood bank, ASH image bank. So here you can see that they can ask you, where are the erythroid precursors present in the bone marrow? Remember, erythroid precursors are always present around the macrophages, and these macrophages of the bone marrow are called as nerve cells, because they are the ones who are going to give iron to the erythroid cells. So remember that. So this is what is called as an erythroid colony. What is this called as? Erythroid colony. So remember, in the bone marrow, erythroids are always located near the macrophages, whereas megakaryocytes are always located near the sinusoids, because they have to release the platelets into the blood. Okay, right. So let's come to the next image based question that can be asked you in exam. This is a 1-year-old boy with hepatosplenomegaly. Remember, if they give you this image, this is one of the repeatedly asked question. This is Gaucher's disease. Everybody knows this. This is crumpled tissue paper appearance. Remember, there are 3 type of Gaucher. I'm sure you all will be knowing type 1, type 2, type 3. Type 1, remember, so remember the code. Okay, instead of gate it is gauge. Okay, so type 1 is adult type and it does not involve CNS, so it's non-neuropathic. Type 2 is infantile type, so it's acute onset neuropathic, it involves CNS. Type 3 is juvenile type, so it basically is subacute neuropathic. Okay, so which is the most common type of Gaucher's? Type 1 is most common, that is adult, which does not involve the CNS. Okay, it usually presents only with hepatosplenomegaly. Now, in contrast, if they change the image to this, these are foam cells, which are very typically seen in Niemann-Pick disease. They are seen in Niemann-Pick disease. And Niemann-Pick diseases are also 3 types: A, B, and C. There are 3 types of Niemann-Pick diseases: A, B, and C. Okay. So always remember, whenever I'm talking about Niemann-Pick, so 2 are most common, A and B are most common. So A, basically it's opposite of your Gaucher's. So A basically involves the CNS. A typically involves the CNS and B does not involve the CNS. Okay, so A involves the brain, B does not involve the brain, and that's the difference between the clinical features of Gaucher's and Niemann-Pick. So remember, is a transport effect. So cholesterol is not trafficked properly, so it will start accumulating and it will lead to accumulation of cholesterol in the tissues. So it's just a transport effect. Okay, right. Coming to the next question. So this is a 3-year-old boy presenting with multiple transfusion and the bone marrow is given here. So I hope everybody can understand this. This bone marrow contains a lot of fat. Normally the ratio of fat to cell is 1:1, but here in this condition fat is excessively increased. So that means this patient, the hematopoietic cells are decreased. So this is a case of aplastic anemia. So this is a case of aplastic anemia. Everybody should remember the criteria here. This is called as Kamita criteria of aplastic anemia, which you all should remember. And you have to take the 3 lineages: WBC, platelet, and red cells. Okay, absolute reticulocyte count. So ANC, you less than 500, platelet less than 20,000, and absolute reticulocyte count also less than 20,000. So that's the criteria. That's a criteria. Is this criteria which I have told you is a criteria for severe aplastic anemia. So if I have to change it to very severe aplastic anemia, everything will remain same. Only thing is ANC will become less than 200. That's it. That's the difference between a severe and a very severe aplastic anemia. Other things are same. Okay. So you should remember the criteria. And since it's a child, you should always rule out inherited bone marrow failure syndromes, especially Fanconi's anemia, which is a DNA repair defect. So this test is called as stress cytogenetics. So you expose the DNA to mitomycin C, okay, or dipoxybutane. So you expose it to mitomycin C or dipoxybutane, and when you expose it, the DNA is broken in you and me, but both of us have proper DNA repair mechanism, so it will repair. Whereas in Fanconi, which is a DNA repair defect, DNA will not be able to repair properly, and you will see abnormal joining of the DNA here. This is called as radial formations, which are very, very characteristic of Fanconi's anemia. Okay. Right. Coming to the next. So this is a 55-year-old female with itchy and eczematous lesion, nipple lesion, and very important repeatedly asked question. Remember this. This is everybody knows this is Paget's disease. Always remember when I'm talking about breast Paget's disease, it's usually associated with an underlying malignancy, whereas in cases of vulval Paget's disease, underlying malignancy is usually not present. Okay, so that's the difference. And of course, if somebody asks you what is the IHC marker, then you can do here. It is usually HER2/neu positive. Of course, it can also be positive for CD5/6 and CD7 also, CK7 also. So remember, but the most important stain that we use here is HER2/neu, which is important stain for Paget's disease that you always have to remember, and it can be CK7 positive also. So it depends upon the underlying phenotype basically. So so remember, usually they are HER2/neu positive and usually they have an underlying malignancy. Okay. So coming to the pap smear. Okay, so pap smear is a very important question again, and they can give you image in pap smear anywhere. So if they're looking at this multinucleated cells, okay, showing you 3M, What is the 3M of HSV? So this is multinucleated cell, and it shows margination. What is margination? That cells are pushing into each other. Okay, so their margins are not identifiable, and they are also showing you sorry. So that is the molding. Okay, so when they're pushing into each other and the nucleus is pushing into one another, that is called molding. And what is margination? That is the chromatin has moved to the periphery. Okay, so it has become clearer. Okay, so remember the 3 M's here. Okay, so it has multinucleation. Okay, it has molding, that is they bulge into one another, so the boundaries are not well defined. And margination, so name itself says margin. So what happens in the margination? The chromatin has moved to the periphery and cell appear a little clearer and the inclusions become visible nicely. Okay, so these are 3 M of HSV. HSV can be given in any organ of the body. Apart from that, you should also remember, always remember, coilocytes is one of the favorite question that can be given to you. So they usually have a raisin like nucleus. What is raisin like nucleus? Like a kishmish. Okay, so it will have little crumpling and it will be little big, and there'll be perinuclear halo around them. So this is what is called as coilocytes. They are very typical of HPV infections. So this is HPV. They can give you HPV in any form. You have to remember these are coilocytes. So HPV infected cells in the pap smear is coilocytes. They can also ask you that which type of lesions, in which type of lesion coilocytes are more commonly seen. Remember, it can be seen in L cell usually. Okay, so L cells are usually associated with a lot of coilocytic changes. Okay, also you have to remember this typical appearance, this tangled cotton ball like cluster whenever they give you, this is actinomyces, and it is usually seen in females who are IUCD users. Apart from this everybody knows, what is this trichomona? Okay, so trichomona is basically she winks one eye, so there is only one eye, and there is a long undulating hair which she has. So this is a trichomona. She winks her one eye and she has a long undulating hair which is there. So this is trichomona, which you have to differentiate from giardia, who has two big eyes and mustaches. Okay, so remember that always. Okay, so trichomonas is one of the very important question. Remember, whenever we have trichomonas, the background usually contain, long thread like organisms which are called as leptothrix. Okay, so trichomonas is usually associated with leptothrix infection. That's a clue that it's there. Okay, right. Apart from that, this is one of the favorite questions that everybody would have seen in gynae, that a cocovacilli attaching to the edge of the squamous cell, and these are called clue cells. Okay, so these are very important. You have to remember with vaginosis. Okay, so bacterial vaginosis will have these cells. Apart from that, you have to remember this. So we can see, we can have a lot of preparation how we do pap smear. We can have a conventional, in which usually we do ethanol, we fix it in ethanol. But now we have two type of liquid based cytologies in the market. We have sure pap and we have thin prep. In sure pap, what happens is we cut the head of the broom and put it in the fixator, and usually the fixator that we use in sure pap is ethanol only, just like the conventional one. Whereas thin prep, what happens is we use methanol as a fixative here. Apart from that, you always have to remember, so whenever we are sure, okay, so the circle is usually small. Okay, that is why you'll be sure, because you'll screen everything. So the size here is 13 millimeter, whereas thin means he's very thin. Okay, so the size will be approximately 20 millimeter, but the size, so the circle will be little bigger, but it will be very thin. So 20 millimeters. So the circle size you should always remember. So sure means it should be smaller circle, that is 13 mm. Then you'll be able to screen it better. Okay, coming to the next question. So this is an elderly male who presents after renal transplant, and again an electron microscopy is shown. So whenever the tubular cells, okay, post transplant show you these changes, these are very typical of polyoma virus, guys. You should always remember it can be polyoma virus, which can be seen on electron microscopy, or on morphology also. You'll be seeing a lot of inclusions in them, so they'll become bigger and start showing these ground glass inclusions. This is very typical of polyoma virus. And then these tubular cells can even shed in the urine. So when they're shed in the urine, they will again have that clear big ground glass nucleus coming in the urine, and these cells are called as decoy cells, and they're usually confused with malignancy. Okay, so remember that post transplantation you should be very cautious that you might have decoy cells, patient might have polyoma virus infections, right? Okay, right, coming to this, and with this we finish the session. This is the last question of the day. Which of these what is this body and which tumor? All of you know this. So there is a central vessel around which these cells, epithelial cells, are there, and then there is a space which is lined by flattened cell. So this is nothing but a Schiller-Duval body, and this is seen in yolk sac tumor. With that, we finish the session. These were some questions that can be asked in an exam. It was just a quick recap. I hope you're preparing well. All the very best for your exams, and we'll be doing a tentative exam question pattern, which I'll do it on 5th of May. So you can follow me on Insta or Telegram or for daily quizzes on Dr. Vandana pathology, and I'll be happy to take any questions if there are any. Right, guys? With that, we finish the session. If there are no questions,